Dr. Jose Maldonado needs very little introduction to the membership of the ACLP. Right now, he's the Associate Division Chief of Adult Psychiatry for Psychosomatic Medicine and Consultation-Liaison Psychiatry at Stanford University Medical Center. And he's board certified in adult psychiatry, CL psychiatry, forensic psychiatry, addiction medicine, and forensic medicine. Dr. Maldonado is well known to our membership, partly because he's received the Hackett Award, the D. Lynn Fisher Award, and the Dorfman Award from the ACLP. He is known academically for his development of the SIPAT, the PAUSE scale, and his talks on delirium and alcohol withdrawal are consistently some of the most popular events at the annual meetings of the ACLP. Today he's going to be presenting an invited presidential lecture about critical care psychiatry, unique challenges in the management of sleep, pain, and delirium during ECMO treatment. Through his work in critical care at Stanford, Dr. Maldonado has modified delirium and agitation protocols for the management of patients on ECMO. He'll educate us about how ECMO alters the pharmacokinetics and pharmacodynamics of analgesics and sedatives. He will help us to know how to manage pain and delirium in these complex patients. We're so thrilled that Dr. Maldonado accepted our offer for this special invited session.
Good afternoon and welcome to this ACLP special presidential lecture. My name is Jose Maldonado. I'm a professor of psychiatry, medicine, and emergency medicine at Stanford University and the chief of the Division of Medical Psychiatry. I also have the pleasure of serving as the fellowship program director for Consultation-Liaison Psychiatry at Stanford and being the medical director of critical care psychiatry. I first want to thank Dr. Maria Tiamson-Kesab and Dr. Lisa Rosenthal for inviting me to deliver this lecture. Today, I'm going to talk about the unique challenges in the management of sleep, pain, and delirium on patients who are undergoing treatment with the ECMO system or the extracorporeal membrane oxygenator. With regards to this presentation, I have not relevant financial relationships to disclose. As we all know, delirium is a neurobehavioral syndrome caused by the transient disruption of normal neuronal activity. And it seems to be characterized by 5 core group of symptoms. The first 2 are the global disturbance in cognition, as well as impairment in attention and concentration, which are paramount to the diagnosis of delirium, according to the DSM. We do know that most patients who experience delirium also suffer disturbance in the circadian rhythm, often associated with sleep disturbances. Many of these patients have irritability or some other form of emotional dysregulation. And then finally, we have a psychomotor disturbance that grant delirium is characteristic phenotype. The important thing to know is that even though we always were taught about the fact that patients with delirium have waxing and waning, really it is a problem of alertness and vigilance rather than the fluctuation that we should be paying attention to. A few years back, we wrote a manuscript regarding the system integration hypothesis failure of delirium. And I just want to quickly summarize the fact that we have patients who come in with a given number of delirium substrates, upon which a number of acute precipitants of delirium act upon. And of course, we coined the mnemonic N acute brain failure to sort of remind ourselves of the many factors that can trigger or precipitate delirium. Once those precipitants act upon the delirium substrates, we tend to have either a dysregulation of normal neurotransmitter activity or an network disconnectivity. It is the combined effect of these last 2 factors, the dysregulation of neurotransmitter as well as the changes in network connectivity, that lead to the phenotypes of the acute brain failure or delirium syndrome. Now, there are many, many causes of delirium, and I don't have time to explore them all with you. But suffice to say is that the three topics of today's talks, pain, sleep disturbances, and delirium interact with each other, affecting each other's manifestation, and then contributing to the symptoms for which we are called. We need to remember that age, frailty, baseline cognitive functioning, and illness severity are all the main important factors leading to the development of delirium. But there are many other things, like all the medications that we give these patients and all the things that we do to them that will also interfere or affect how the patient responds. Let's briefly talk about the ECMO system. ECMO stands for extracorporeal membrane oxygenation. And it is a system that is utilized in order to further oxygenate the blood, essentially serving as an artificial lung, and then pumping the blood back into the human body. There are essentially two main types of ECMO. There's the VV ECMO, or a venous ECMO, where used mostly for pure respiratory support, and that is on a patient who has preserved cardiac function, or the VA ECMO, where you have a separate venous and arterial return, which is mostly utilized in order to bypass both heart and lung function, therefore providing full cardiac and pulmonary support system. It is a complex system which includes feet and feet of lines that go from the oxygenator to the body, as well as the membrane oxygenator, both of which will become a prominent feature later in the lecture. The ECMO system is really not a treatment, but a form of life support that normally is used in order to bridge a patient from the state of illness to one of these three conditions. It's either a bridge to recovery, in the cases of a reversible condition. Many patients with COVID pneumonia will fall into that category. It is a bridge to a device where the patient is going to be moved, for example, from the ECMO system to a left ventricular assisted device, or it's a bridge to transplantation, either heart transplantation or lung transplantation. And these are the conditions in which you will consider using either the VV ECMO or the VA ECMO. Now, why is it important to consider and think about delirium in ECMO patients? Well, we do know that delirium has been consistently been shown to be an independent predictor of poor medical outcome, particularly on patients who are critically ill. In addition, there is evidence that patients, once they recover from delirium, they continue to have long-term cognitive impairment. Finally, it is important to remember that the data suggests that the sicker you are, the greater the incidence of delirium. So as we know from Parandepindia and colleagues in the previous study in 2006, the greater the Apache 2 score, which is a measure of acute illness, the greater the probability of transitioning into delirium. There are multiple forms or phenotypes of delirium. Almost always we start with a subsyndromal form of the delirium, and then it manifests itself into one of three types. There's the hyperactive delirium. We tend to get really excited about it. In patients with ECMO or ventilators, it becomes really important because it might lead to accidentally extubating themselves or removing a line. But the important thing to remember here is that hyperactive delirium occurs in only about 10% of the patients. The majority of the delirium tends to be either the hypoactive, which occurs in about 70% of the patients, or the mixed type delirium, which occurs in about a quarter of the patients. The important thing is to remember that there's usually sort of a increasing manifestation or tempo in the development of delirium, eventually having the extreme excited delirium or catatonic excitement, and then the catatonic retardation form of delirium for those patients who have hypoactive delirium. In our experience, most of our ECMO patients have manifested a hyperactive delirium requiring aggressive management with sedatives and psychotropic agents. And then usually after the transplant, once they get off the system, they manifest some of the hypoactive or mixed type forms of delirium. It is also important to remember that among critically ill patients, delirium has been consistently shown to be an independent predictor of poor, both short and long-term outcome. Just wanted to point out on previous data published by Pisani and colleagues to remind ourselves that delirium, the occurrence of delirium is the first hit, but then you get a second whammy depending on the duration or the longevity of the delirium. And as you can see, having delirium is bad, but the longer that delirium lasts, the greater the morbidity and mortality associated with that episode. There are multiple factors, as we discussed before, for the development of delirium. Parandipindia and colleagues have already demonstrated that increasing age and the use of certain medications, particularly some of the GABAergic agents like benzodiazepines, have been shown to, as increasing the dose of the delirium, so does the probability of transition into delirium. Similarly, Dr. Smith and colleagues have similarly demonstrated that the increasing doses of benzodiazepines have been associated with the development of delirium in very young children. We also know that hypooxygenation and any factor that is associated with cerebral desaturation has been associated with a dramatic increase on the risk of developing delirium. And as I discussed earlier in this meeting, when we were talking about infectious processes, particularly COVID-19, we know that infections of any kind, whether they're bacterial, fungal, or viral, can lead to a dramatic development of a cytokine storm that has been associated with the development of both delirium as well as long-term cognitive impairment. At the end, I think that the most important thing to remember here is that many of the things that we do to patients in order to keep them safe, or sometimes even to save their lives, such as the ventilators, the ECMO system, the cannulas for hemodialysis, all serve as restraint, and the use of restraints, painful procedures, and the use of medications like benzodiazepines and opiates have all been associated with an increased risk of developing delirium. Now let's talk about why is it that I'm particularly talking about the ECMO system. During the course of the pandemic with COVID-19, the number of adult patients requiring ECMO system has exponentially increased, and the literature reflects that that is not unique to Stanford. There are many reasons why patients who are on the ECMO system required analgesia and sedation. And that had to do with reduction of oxygen consumption, obviously facilitating synchrony with the ventilator system, diminishing the amount of distress and discomfort that the patient experienced. And then, of course, to prevent the patient from accidentally getting themselves dislodged. Depending on the type of ECMO system, whether we're talking about a VA or a VV ECMO, you see that the number of cannulations and lines that are being used is going to vary from patient to patient, depending on the system. In fact, sometimes we have had patients who require 2 systems at the same time because of the amount of support that the patient needs. And then, of course, there is the possibility that if the patient starts moving themselves, the ET tube can come off. So there are many reasons we need to sedate these patients, one of which is the management of delirium with agitation itself. There are a number of factors, as you can assume, such as cannula malposition or impairment of the venous drainage due to increase in intra-aortic pressure, leading to shocking on the ECMO system, intravascular changes in intravascular volume, or even changes in position that are going to affect how the patient experiences themselves, and therefore how it affects the flow through the machine. The ECMO system is a very low pressure system, so almost anything that causes a Valsalva or increased intra-abdominal pressure can cause what is called shocking, which then leads to problems with the flow and return. It is important to also to know that most of the data published to date suggests that most patients who are on the ECMO system are very deeply sedated. And most of them require continuous infusion of any number of medications, particularly the GABAergic agents like midazolam and or propofol. And then a significant number of these patients are also taking one of the various opiates, usually in IV formulation. I want to point out that most people have found that when they are using these agents, they're using extremely high doses of these medications, as you can see here. And there is a very good reason for that, which we're going to discuss in a few seconds. So just wanted to point out, almost everybody requires high levels of sedation. The doses of medications that we're using are usually on the very, very high side. And many patients, nearly half of them, will also require restraints. I'm sure that you all know the various sedation scale. We tend to favor the use of the Richmond agitation and sedation scale because it gives us a range from both the positive as well as the negative spectrum. And of course, many of the assessment tools for delirium require that you document the RASS score on various patients. Ideally, our patients will be on the 0 range, but anywhere between -1 and +1 is probably acceptable. Now, there are significant reasons why patients are requiring so high doses of medications. As I mentioned before, the ECMO system is a very complex system. Many of these patients are not only on ECMO and the ventilator, but they're also at the same time on either hemodialysis or CRRT. That causes significant changes on the volume and distribution, which is going to affect particularly hydrophilic medications. There are changes in both metabolism and drug clearance. And one of the most important factors that I want to spend a few moments with is the issue of sequestration. And sequestration is usually associated with how lipophilic the medication is. As I mentioned before, the ECMO system is a very complex system. You can see in this patient here, he is on the ventilator. That's an EEG monitoring. This is the ECMO system, and the patient is also on CRRT in the back here. So there are tons of lines, there's tons of machines, and I just want you to pay attention to the dozens of feet of PVC tubing that go from the patient into the system and back. Lines and lines and lines on which medications might be sequestered. And this is an example not just of the number of lines that come in and out of the patient, but also the membrane oxygenator, both of which are the main source of problem. I mentioned the word sequestration before, which is a very well-known phenomenon, particularly on the ECMO system. There are two main factors that would lead to sequestration. The first one is the drug's protein binding capacity, and the magic number there will be over 80%. And the second one is how lipophilic the medication is as measured by a log P value. And here, what we really care about is a log P value of greater than 2.4. It is a combined effect of those two factors that are going to determine how much of the medication will actually get to the patient's CNS and how much of it is going to be sequestered. Just as a comparison here, I just want you to see here on gray is the patient's normal levels of fentanyl before the ECMO system is turned on, and that almost disappears, as you can see here, once the system is started. The same thing happens with midazolam. You see on gray here, that is a normal midazolam level, and without changing the doses, just by turning on the system, you see that there's a dramatic reduction on the patient's medications level. Some medications are very low in lipophilicity or protein binding, such as morphine, therefore maintaining an adequate level, even though the patient has been placed on the system. So then we realize that it is the combined effect of both the log P value as well as the protein binding that will determine how much will the patient's brain see of the medications that we're dripping on the system. As you can see here, fentanyl and propofol, two of the most commonly used medications, a GABAergic agent and an opiate, are among the most likely to be sequestered, followed by the presence of midazolam and then propofol. You see that dexmedetomidine, one of my favorite drugs, is fairly high on protein binding, but relatively low in log P, and that will allow for some balance between the two. So the question is, which medication are we going to use and which one is the safest? We already talked about the main insults. And for those of you who have seen my talks before, you know that I like to simplify things by sort of summarizing the fact that in most patients, particularly with agitated delirium, we're seeing significant increases on the availability of norepinephrine, dopamine, glutamate, and an activation of calcium channels, as well as reduction in acetylcholine, melatonin. And then depending on the type of delirium, we're going to see variability in levels of orexin, serotonin, histamine, or GABA itself. A reminder, from now on, I'm going to be talking about various medications combinations for the management of pain, sedation, and delirium in ECMO patients, but there's no FDA-approved pharmacological intervention for the treatment of delirium. So, as I mentioned before, all of these are the neurotransmitters that we sort of care about on patients who are acutely agitated on the ECMO system. I'm going to start the discussion with the norepinephrine system. Alpha-2 agonists are among my most favorite medications, and the main reason for that is the delirium sparing effect. By using medications like dexamethasone or guanfacine, we actually minimize the need for some of the other medications that we normally use in the ICU. Alpha-2 agonists bind to the presynaptic adrenal receptor in the locus coeruleus, which leads to a significant reduction on the release of norepinephrine. Through modulation of noradrenaline transmission, alpha-2 agents or alpha-2 agonists promote sleep by unique hypnotic mechanisms, which both enhance deep sleep without necessarily affecting REM sleep, as we see on GABAergic agents. Through their action on the alpha-2 adrenal receptors, dexamethasone and other alpha-2 agents inhibit the release of glutamate. And this modulation of excitatory neurotransmitter leads to these agents' delirium sparing effect. So they have sedative, anxiolytic, antinociceptive, and sleep promoting effects without the need of other medications that are routinely associated with delirium, such as GABAergic agents and opiates. It is also important to know that alpha-2 agonists also have significant neuroprotective effect. Some of that is mediated by increased astrocyte expression of BDNF, but there is also modulation of protein kinase, inhibition of apoptotic pathway, increased expression of active focal adhesion kinase, and decreased calcium changes mediated by glutamate receptors. There's also some data to suggest that guanfacine reduces hyperactivity and improves cognitive impairment, particularly by activation of adrenal receptors in the frontal cortex and the frontal limbic network. The three available alpha-2 agonists in the United States are listed on the chart on top. You see clonidine, dexamethasone, and guanfacine. I want you to pay attention here to the selectivity of these agents. So as we go up in the scale on the bottom, as we go up on that scale, you see that the agents become increasingly more selective. The advantage, of course, of dexamethasone is that it has an extremely short half-life. Usually the patients see an effect within 10 minutes or so of initiating the infusion, with a peak plasma effect in about 45 minutes or so. Now, as I mentioned before, dexamethasone is not devoid of potential problems. It has a log p-value of 2.8 and a protein binding that is fairly high at 94. So that means that we expect the combined effect to essentially say that dexamethasone might be moderately sequestered, and that indeed in studies that have been shown to be the case. We should assume that about 50% of dexamethasone will be sequestered by the ECMO system. In opposition to that, you have guanfacine, which is only available orally, so your patient must have PO access. It unfortunately has a fairly long half-life. The half-life is nearly 20 hours, which means that it's going to take some time to build up to effect. The advantages, though, is that it has a log p-value of less than 0.9 and a protein binding of about 70%, thus predicting that guanfacine will not be as sequestered as its competitive alpha-2 agonist dextromethatomadine. Unfortunately, there is no good data on studying the effect and the blood levels of guanfacine on patients on the ECMO system. So here we're going by what the literature and the data will tell us. One of the things that we do like about the use of dextromethatomadine is that given its very short half-life, you can dex cycle. That means that you're going to put the patient sort of down by increasing the amount of dex that the patient is using during the nighttime. And then at about 4 a.m. in the morning, you start reducing the infusion of dex, trying to peak or going to the lowest required level to achieve a RAS of around 0 to +1, and therefore decreasing the amount of medication that the patient needs during the daytime. And then the next night, you do the same thing over and over again. This decreases the amount of dex that the patient requires during the 24-hour period, as well as it more mimics a normal circadian rhythm. Remember, one of the advantages of alpha-2 agonists, including dextromethatomadine, is the fact that it induces sleep, it promotes deep sleep, but it does not affect REM sleep. Last year, we did a study in which we were looking at patients who we had in the ICU on a dex drip. And then we added guanfacine, initially in an attempt to facilitate getting patients off dextromethatomadine. In our study, about 80% of the patients were delirious. And what we discovered was that about 56 hours after we started the use of guanfacine, which correlates with the half-life of the medication, we saw a statistically significant reduction in the use of all required and PRN sedative medications. Specifically, what we saw was a reduction of nearly 10% on the use of benzodiazepines. That reduction probably was not greater because at Stanford, we don't use that much benzodiazepines in the ICU. We saw nearly 60% reduction in the use of opiates. Important to remember that opiates are probably the #1 medication associated with the development of delirium. And then about 13% reduction in the use of PRN antipsychotic medications for the management of agitation. So moving on to the use of medications with GABA activity or GABAergic agents, you can see on top propofol, which is a favorite of our colleagues in the ICU. Midazolam is slowly decreasing in terms of its popularity, but just wanted to point out that the mechanism of action is similar for both of them, primarily the GABAergic activity. But there are significant problems with both propofol and Versed, and that has to do with this: a very high log p-value on both agents and an extremely high protein binding activity. So it is predicted that both agents will be highly sequestered by the system. And in fact, the data shows that nearly 75% of patients on Versed and nearly 100% of patients on propofol will experience significant problems with sedation, requiring greater than usual doses of what we normally use to sedate patients. Of course, we know that lorazepam has been associated with the development of delirium, but I just want to point out here that lorazepam, among all the benzodiazepines, along with alprazolam, have the most favorable log p-value. Lorazepam still has a relatively high protein binding, thus making this agent about moderate, but there's still 40% sequestration. Of course, when we use lorazepam, particularly in IV formulation, we need to be concerned about the possibility of propylene glycol toxicity, which we not uncommonly see. Because of our studying of this matter with ECMO patients, we have decided that we needed to go back to the drawing board. That's how these tables got created, by combining all the available data in the factors that lead to sequestration. And to our own dismay, we discovered that there are some agents that we have not been using in the recent past, but that are very favorable for patients who are on the ECMO system. And those are our good old friends, the barbiturates. As you can see here, phenobarbital has a log p-value of less than 1.5 and a moderate protein binding potential. Similarly, pentobarbital has a relatively low peak value and an even lower protein binding activity. Because of the half-life, pentobarbital is usually used as an IV drip, while you can give boluses of phenobarbital. One of the two main differences have to do with the half-life. The half-life of pentobarbital being about somewhere around 20 hours, while the half-life of phenobarbital is in the 80s to 90 hours. Now, we need to remember how these medications work because we haven't been using them as often. And I just want to remind particularly the trainees that the GABA receptor complex is a very complex system. It has its own receptor for GABA. And then there's the sites where all the other medications that we use will bind in. Now, remember that all these medications tend to basically cause an allosteric change. So benzodiazepines, for example, themselves do not activate the chloride channel. What benzodiazepines and zolpidem and others do is by binding here cause an allosteric change, facilitating GABAergic activity, but they require GABA to work. As this one here shows us how much more complex the system is, and of course, the differences between benzodiazepines and barbiturates. As we all know, benzodiazepines increase the frequency of the opening of the chloride channel, while barbiturates prolong the opening of the channel itself. Now, one of the things that I'm going to show you in a second is the fact that even in the absence of GABA, the barbiturates will activate the channel, which might be an alternative for some of our patients, and one of the reasons why our patients might have responded so well to our new protocol. As you can see here, all the GABAergic agents that we normally use have very specific and different sites. Propofol, for example, is always between the beta and the alpha subunits. Benzodiazepines are always between the alpha and the omega subunit. And the C drugs, like zolpidem, they have a unique receptor site, which you probably could have seen on the previous image too. So not all these medications are created equal. The other thing to remember is that these medications have different activations on the various alpha subunits within the GABA receptor complex, giving these medications their unique qualities. As you can see, some of the agents act on the extracellular part of the receptor complex, while medications like barbiturates or alcohol act in the transcellular component of the receptor site. And as I mentioned, the Z drugs have their own unique site, which is just next to where the GABAergic system is. I know that some of you have not been using barbiturates for a long time, so I just wanted to give you some basic reminders. Pentobarbital is about 13 times more lipophilic than phenobarbital, which means it's going to act significantly faster, and it will probably leave sooner. It has a significantly shorter half-life. You can also achieve this anesthetic effect 10 times more rapidly once you use it intravenously. The other thing to remember is when you consider the barbiturates itself, is that at low macromolar concentrations, barbiturates act in very similar ways to benzodiazepines. So they enhance the activity of submaximal concentrations of GABA. But at higher concentrations, barbiturates can activate the GABA receptors themselves, even in the absence of GABA activity. So, for example, you never heard this from me before, but if an alcoholic patient was not responding to our benzosparing protocol, I would probably consider a barbiturate rather than a benzodiazepine. And then at the highest concentration, you can essentially stop the flow of current in the chloride channel. These differences are one of the main important factors for which we think that benzodiazepines in general are better to barbiturates. It's a factor of safety, and the fact that the therapeutic index and the toxic index tend to be too close for barbiturates. But we're talking about patients who are in the ICU, who are ventilated, who are on the ECMO system, and those are the only conditions in which we will use these medications. Also remember that some of the GABA receptors might be entirely formed by by beta subunits, which are unresponsive to benzodiazepines, you say here, but they still can be activated by phenobarbital. Finally, remember that even though benzodiazepines act exclusively on the GABA-A receptors, barbiturates have a multitude of other actions, including diminishing glutamate responses, inhibiting both sodium and calcium channels, and then inhibiting glutamatergic release. So moving on to the analgesics, all of these are opiate agents. I just want to point out here that not all opiates are created equal. Of all the medications, remember, we're looking at this column here for the combined effect of the log p-value and the protein binding activity. You see that of all the medications we have available, morphine, hydromorphone, and oxycodone will be our favorite agents to use on ECMO patients. Hydromorphone, which is available IV and often is used by ICU colleagues as part of the narcosedation protocol, will have probably one of the most favorable profiles when it comes to sequestration. Morphine is not bad, but there are significant problems with morphine. One, there's an increased incidence of delirium with this agent. Two, there's evidence of significant histaminergic release, which might lead to both hypotension and bronchospasm. And then when the patient can take medications by mouth, oxycodone will probably be our favorite agent. The use of ketamine has been considered at various times as we were creating the protocol. It does decreases the need for opiates in most patients. It has a moderately favorable profile, but of course, there's the problem of delirium induction, particularly as you remove the agent, also what we know about as emergence delirium. Lidocaine, we're suggesting its potential use, particularly on patients who are chugging on the system because of coughing or gagging, excessive gagging reflex because of the endotracheal tube. And the way we use it is nebulized. So the patient inhales it, and then it significantly decreases the coughing and the gag reflex. Moving on to the anti-glutamatergic agents, many of you have heard other talks where I talk about the wonders of valproic acid. And as you can see here, one of the problems with ECMO patients is that VPA will be moderately sequestered. On the other hand, its cousins, gabapentin and pregabalin, are not. In fact, these agents are very much hydrophilic rather than lipophilic, and they will not be sequestered by the system at all. We have been moving away from the use of gabapentin in favor of pregabalin, and I'm just giving you the data right here. So mechanism of action is pretty much the same, inhibiting calcium influx and decreasing excitatory transmission. But there are some significant benefits of pregabalin as compared to gabapentin. The first one is that gabapentin is absorbed from the GI tract by a saturable pump. And as the doses goes up, the bioavailability decreases. As you can see here, at doses of 300 milligrams a day, the patient is getting about 80% bioavailability. When you increase the dose to 900 a day, that decreases to 60%. And when you go to the full dose of 3.5 grams, that decreases to 30%. On the other hand, there's a linear absorption with pregabalin. So the more you give, the more the patient gets. The other difference is that gabapentin is absorbed just in the first portion of the small intestine. So patients who have had GI surgery that include that portion, or if there's a lot of edema, they might not be able to appropriately absorb the medication, leading to failures of the medication. On the other hand, pregabalin is absorbed pretty much throughout the entire small intestine, not just the proximal portion. And then finally, there's the peak plasma effect, which is about 1 hour for pregabalin, but 3 to 4 hours for gabapentin. Of course, they're not exactly the same mechanisms of action. All three agents cause inhibition of calcium channels, but valproic acid has significantly wider effects, probably why it has an enhanced response. Talking about which, and looking at the effect of anticonvulsants, when you look at how these anticonvulsants work, we, of course, have been just talking about calcium channels, calcium channels, chloride channels. I realize that I've been saying calcium channels when we meant chloride channels, sorry. But, there are effects of these medications on both calcium as well as sodium channel. And if you look at what is common to all of these pathways, you have two agents, valproic acid as well as barbiturates, that will affect transmission through all three mechanisms, probably leading to the enhanced effect of all these agents. Moving on quickly to sleep physiology, which is really important to maintain on patients who are in the ICU, particularly the critically ill. Just want to point out that there's kind of an alternating relationship between orexin and melatonin. So early at night at around 9 p.m., you see that the secretion of melatonin begins, the secretion of orexin ends, and then that goes on until about 7, 8 o'clock in the morning, when you have the opposite happening. Melatonin secretion stops and orexin secretion starts. That is associated with a number of factors that we need to be mindful. In fact, remember that the main function of melatonin is to set the circadian clock or the circadian rhythm. Of course, sleep has to do with the circadian rhythm, but there are many other physiological functions that follow a circadian rhythm. And I just wanted to point out to you that thermoregulation, mean anterior pressure, cortisol, testosterone levels, and even insulin are all following the circadian rhythm. So when the circadian rhythm is disrupted on critically ill patients, all of these functions are disrupted. If we synchronize all of these charts here, this is 11 p.m., you see that with the peak of melatonin, you also have a bottom of the map or the mean arterial pressure, as well as cortisol levels. And that is important for us to remind our colleagues, because many of our patients do develop hypotension in the middle of the night, which is probably associated with both the use of medications and the fact that now the patient is probably finally sleeping. I already showed you this, but I wanted to actually, this should be not mapped. This is orexin levels. So as you can see that there's a counterbalance relationship between both. And this is from a study of Olofsson and colleagues, showing that when patients get admitted to the hospital, they have normal levels with variability of serum melatonin. But after a few days in the ICU, that has been dramatically suppressed in almost every patient. Over 85% of the patients will have suppression of melatonin. That leads to the agents that we could use for the management of sleep, or hypnotic agents in the ICU. And as you can see from this chart that we created here, when we're thinking about melatonin or melatonin agonists, obviously using pure melatonin, or as an alternative, a melatonin agonist or Ramaltion. The benefits of using Ramaltion are that you get pharmaceutical grade medication, and of course it has a significantly longer half-life. I tend to prefer using melatonin itself, but there are some significant problems. The main problem is that the half-life of the medication is extremely short. It's only about half an hour maximum, with a peak effect in an hour. It has moderately good bioavailability, but the problem is that it doesn't follow the normal pattern of melatonin released by the pineal gland. So in an ideal world, if we're going to use melatonin, we should be using slow release melatonin. So it's released all through the course of the night, just like the pineal gland will be releasing melatonin all through the night. In the absence of, slow release melatonin, or the patient who is intubated and not taking medications by mouth, if you're going to crush the slow release melatonin, that just turns into IR melatonin. In those patients, we will move them from melatonin to Ramaltion. Half-life will not be changed by pulverizing the medication and putting it down the NG tube. When you need more than just a melatonin agonist, the use of a orexin antagonist is desirable. At Stanford, we tend to use suvorexant mainly because lemborexant is not available in our formulary, but I wanted to be completely transparent here. Suvorexant is significantly sequestered in the system, and therefore it probably will not be useful on patients who are actively on the ECMO system. Conversely, lemborexant has a somewhat better profile, not dramatically, but significant to make a difference. When you need the extra help of a very highly selective GABAergic agent, and I already showed you the difference between the Z drugs and the benzodiazepines or barbiturates, the use of citalopram, if you're looking for something that has a short half-life, or esoplicon, if you're looking for something that has a longer half-life, will be desirable. Unfortunately, zolpidem, which is, I think, a fairly good sedative agent or hypnotic agent, will be significantly sequestered by the system and therefore not recommended in our protocol. Now, I was just wanted to remind you that the site of mode of action for the Z drugs is different from that of benzodiazepines or barbiturates, hence the fact that we still consider the use of these medications in some patients. Finally, I wanted to demonstrate that there are some medications that are very useful in the induction of sleep as hypnotic agents without causing significant negative side effects. Probably the number one medication will be the alpha-2s. When you look at the pattern of sleep induction between natural sleep and the alpha-2 medications, particularly dexmedetomidine, they are almost identical. Second to that, some of the Z drugs used at moderately low doses will enhance the ability of the patient's sleep without dramatically affecting the REM pattern. On the other hand, the conventional benzodiazepines and propofol are not that desirable. They all have significant negative effects on the sleep pattern. The same thing can be said about opiates and, of course, as we all know, the steroids. So there are many medications that we can use to enhance the sleep pattern. And remember, our point and our intent is not to sedate the patient, but to actually cause hypnosis. So allow the patient a natural sleep without sedation. Most of our patients who are sedated are not necessarily sleeping. So the production of sleep is what we're looking for. As I mentioned, some of our ECMO patients flip from a hyperactive type of delirium to a hypoactive type of delirium. And when that occurs, we consider the use of psychostimulants. The two main and most favorable psychostimulants will be modafinil and dextroamphetamine. As you can see here, dextroamphetamine has a very favorable profile on patients who are on the ECMO system with a moderately low log p-value and a very low protein binding potential. On the other hand, the opposite is true for modafinil. It has a relatively low log p-value, but a moderately high protein binding potential. The main thing to consider here is probably the cardiac effect of these agents on the patients and what is your patient's unique conditions. If we want to use something a bit milder or a patient who has had a head injury or brain injury, we will consider the use of an NMDA receptor antagonist like memantine. Of course, one thing to consider here is not just the effect of the ECMO sequestration problem, but also the fact that these agents are not really metabolized by the body and purely excreted by the kidneys. Many of our patients have either acute or chronic renal disease, and accumulation of these agents might lead to negative outcomes, including seizures. Finally come the antipsychotics. As you all probably have heard me talk about before, I still haven't found many things that are better for active or hyperactive delirium than haloperidol. And I stand by that even on patients who are on the ECMO system. So when we look at all the available antipsychotics in the market, and we look at their combined effect of the log P and protein binding ability, or what I would like to call the sequestration index, you see that among the lowest of them are haloperidol and paliperidone, followed by risperidone and quetiapine. Of course, all these agents have unique characteristics. Some of them are more favorable than others. If you're looking for something that has primarily a dopamine antagonist effect, you will consider using either haloperidol or aripiprazole. Unfortunately, aripiprazole is highly sequestered, so that becomes less useful in these cases. The use of paliperidone will be then desirable. The main problem with paliperidone is that it's only available on the ER formulation. Once you crush it, you try to put it down the NG tube, you just have IR risperidone. That will be our next alternative, right? So haloperidol IV or risperidone PO. We can sometimes consider the use of quetiapine, but then you have to deal with a very potent antihistaminergic effect, which then causes sometimes excessive sedation. In some patients, that might be a desirable effect, and you just need to think about the characteristics that you're looking for. So in summary, when we think about the management of delirium in patients who are on the ECMO system, there are combinations of non-pharmacological and pharmacological techniques. We designed a protocol that we call the REMS-D protocol. It was kind of a play on words because we want to induce sleep in these patients, make sure that they are sleeping through the night. So the R stands for the restoration of the sleep-wake cycle, and also the protection of that cycle. That means selecting for medications that will least disrupt the cycle. Exercise, the more active these patients are, the better they do. I could show you tons of videos of patients on both the ventilator and the ECMO walking down the hallways, and our physical therapists have done a wonderful job on mobilizing patients. The M stands for minimizing the medications that might interfere with the sleep-wake cycle or contribute to delirium. The S for the search of potential causes of delirium. So at the same time, we're managing the patient's behavior. We're looking for the causes of delirium so we can treat it at the root. And then the D stands for the pharmacological delirium management protocol. And that takes us to the next step, which is either here in blue or in red, depending on whether we're managing hypoactive or hyperactive or mixed type delirium. So almost always we use a melatonin or a melatonin agonist. When that by itself is not enough, we will consider the use of an orexin antagonist. And then, as you probably know by now, what is common to all of our patients is the use of one of the two alpha-2 agonist agents. Oftentimes, we start with dexmedetomidine and then quickly add guanfacine. Remember, it was going to take between 56 to 60 hours to kick in, and that, as it goes up, allows you to reduce and minimize the amount of dexmedetomidine needed. When agitation is a problem, a dopamine antagonist will be used. Haloperidol and risperidone, as I showed you now, for ECMO patients, are probably the two favorite agents, with quetiapine as a third favorite. For excessive glutamatergic activity, we will favor the use of either IV valproic acid or PO pregabalin. There's no good data on the use of acetylcholinesterase inhibitors, so I'm not including that in my discussion. And then, of course, remember that we talked that among opiates, hydromorphone is probably the best, followed by OxyContin. Morphine has been used in many centers, but it has the potential problems that we discussed earlier. And then, of course, if you need to use GABAergic agents in ECMO patients, and the barbiturates are probably the way to go. You can use either phenobarbital in boluses, just the same way you will use normally lorazepam, or you can just convert the patient to a pentobarbital drip with the average dose of about 1 mic per kilo per hour. And then, since most of these patients tend to have hyperactive delirium, I'm not going to spend much time on the hypoactive delirium, with the exception of reminding you that psychostimulants are often needed on these patients, particularly because we want to mobilize them and get them out of bed as early as possible. This slide sort of summarizes what we use in our new protocol for the management of sleep, pain, and delirium management. And all the things that are in that slide have already been covered. I just wanted you to find all the medications, all the agents, and all the doses in one single slide. With that, I finish. Again, I want to thank Dr. Rosenthal and Dr. Tiamson-Casab for their invitation to deliver this presidential address, and want to also invite you to join the critical care psychiatry SIG that we're forming. And it's very unfortunate that we're not going to be together this year, because I would love to meet all of you who are interested in the topic of critical care psychiatry, but hopefully next year. Thank you very much for your attention, and I look forward to comments or questions. Feel free to email me to my address, and I'll try to get back to you with any information. Thank you very much.